So one thing that we've heard this afternoon is some, a lot of data analytics, a lot of, thousands of people with a lot of information being stored, and it sounds like, even from some of this morning's speakers, Google with terabytes of data on each patient. One of the things we haven't talked about is privacy and data security, and all of you all work in large sets of data, and as we start to transition out of the research space to the patient care space, and having large amounts of very important data, very specific to each patient, kind of out there. There's a lot of concerns, and I didn't know about what your thoughts are on our solutions of this. Good luck.
It's an interesting question, because if you ask me today what are the biggest challenges to adopting artificial intelligence, I would say there are two. One is data availability, and the other one is the validation of the algorithms. But starting with data availability, one big issue there is privacy, right? And how you actually would share the data amongst other people. You want to move the science forward. At the same time, you're worried about how the data will be shared. And what's funny is I've yet to meet a patient who said, I don't want to share my data. But yet we're very concerned, because with what just happened, especially with deep learning and artificial intelligence, it turns out that because algorithms are sort of standard, a lot of the value now is moved into the data. So hospitals find it to be very valuable for them. I didn't answer your question exactly, but some of the data concerns related to AI.
So from my perspective, there's one issue that we're struggling with right now, and that is that for these genetic-based approaches, you need truly large data sets. And as I mentioned, we collected our data set internationally. And one of the problems that we have now is that for genetic data sets, there are rules and regulations in the EU that, for example, preclude taking genomic data out of the EU. We've collected data sets in China, but local regulations preclude from taking the genomic data out of China. So now what we're struggling with is how do we actually combine those data sets? There's no regulatory path today to actually now combine genomic data from different continents due to different regulatory requirements, and that's a major challenge. We just have no solution for that today.
So it's not only a struggle right now with research to increase the amount for passing it off internationally, but when that then transitions to the patient care zone, all bets are off, right? We don't even have a roadmap yet.
No, and one of the things we do, I didn't talk about that aspect, but one of the things we do in the precision medicine clinical implementation space is the patient comes in, we measure all these things, and then we benchmark them against our database, right? So the idea is to have this large repository against which then you can benchmark. But again, how do you do this internationally, and how do you, if I collect my data set in Europe, but I have an African American patient come into the office, that's not a relevant comparison, and that's the problem right now.
So one of the things that each of you all touched on, and I know that Vic started it with at the very beginning, is kind of taxonomy of disease. And rather than just having two types of atrial fibrillation or two types of diabetes, or HFpEF versus HFrEF, and our inability to define patient subclasses is just as bad as our ability to treat them, right? And so I guess, will we be able to expand? And is this, as we learn more about the different taxonomies of disease, right, and the different subgroups, do we have the right therapeutics in place to be able to pinpoint who's going to be affected by which?
Yeah. So that's what I was trying to kind of describe with a companion diagnostic approach, right? So, one field that we were looking to learn from is the oncology space, because they've been using biomarkers for a number of years to segment out disease states, right? So when I was in medical school, there were 4 types of lung cancer. Today it's like 600 types of lung cancer on the basis of biomarkers, right? So I think that's where it's going, and eventually you end up with the N of 1, because in the end everybody is different. So I think it's that companion diagnostic approach that will create that segmentation you're talking about.
And Andre, your group is certainly looking at the back end of things, trying to understand how to take all this data and utilize it for, individualized recommendations at each step, right?
exactly. And we're not sure where it's going to take us, but what we're trying to do right now is really create a framework of how we are going to be looking at this data as it comes in, because it's one of those things where you're like, okay, I know there's a lot out there. We are going to look at it, but we're not sure what we're going to notice that other people have noticed before. We're not sure what we're going to see in terms of just when you have a contextual data set that's never really been had before. Will we understand new things about hypertension? Will we understand new things about sleep or activity that we've never seen before? To me, I think one of the areas that's going to be really interesting, but will probably be a few steps down the line, is obstructive sleep apnea. Because when we can tie that to arterial CO2 levels and blood pressure and activity with accelerometer data, it's going to be really interesting to see, what we can come out of it. I mean, it could be just as simple as, this is the position you should be sleeping in, right? But,
See, what I find interesting is a lot of these classifications that we have today are sort of targets that we've set for ourselves so we can deal with today's data, right? So we can't say that for each person, here's the medication I want to give you, so we create buckets of these people, right? It's like, well, people like you fit in this bucket, and that's the recommended sort of medication. But if we look at the future, I really don't see the need to do that. We've had the need to do that because we can't handle all of this data and learn from it and individualize all the treatments that we provide. But in the future, I almost don't see a need for this sort of classification, right? If you're able to bypass these targets, you can become much more efficient and reduce sort of the inaccuracy and the error that you see today.
So, it was brought up early on, the article by Siddhartha Mukherjee in the New Yorker, which many of you in the room have read. If you haven't read it, you should. And so, Bill, I'll ask you, one of the points in there was, we're getting such great insight from these big data sets and algorithms that as physicians, we just have come up short on, and it seems like that there's going to have to be a reorganization of our way of practicing medicine and thinking about diagnoses, et cetera. And there's going to be a lot of resistance, I would expect. And what do your colleagues think about when you're talking about these big data sets and, wow, am I going to be needed anymore?
Well, I think there is a tendency for people to react that way, but we just have to reassure them and convince them that the answer is yes, you're still going to be needed, and that these are tools. Somebody said it earlier in the day. These really are tools. We're just providing clinicians with better tools, to diagnose and to treat disease, and to do it in a much more precise way, in a much more individualized way. So I think it will take a lot of reassurance, but certainly, physicians may touch hundreds or thousands of lives during their career, but the machines can touch millions, tens of millions, and the learning can be much more quick. And we've got to take the lessons from that, and we've got to use those tools. So I think we just need to reassure physicians that these are tools, and they'll provide us with information that has much higher fidelity than everything else we've seen in the past.
Yeah, and I think that the involvement of the physicians early on is so critical. I mean, I look at the healthcare and artificial intelligence literature, and about 15% of this is targeted at cancer, right? Which makes sense. But cancer is the second leading cause of death. Cardio is. Only 4% of literature is on cardio today. There's such an immense opportunity for us today in this field to actually have a huge impact and drive this forward.
Any questions in the audience right now, Rigvin?
No, there's some.
Okay. So you had mentioned, getting physicians, I guess more directed towards you, but just anyone in the panel really, about getting physicians involved, specifically in artificial intelligence. And, I guess to a group of cardiologists here, can you describe kind of, we often, as much as we don't love algorithms, we think algorithmically, right? Let's say you have a cardiologist who wants to be involved in the AI space. In what ways, tangibly, are you sort of making that happen if someone were to approach you?
Yeah, so I recognize that it's not very easy to make every cardiologist a programmer, It's not very easy to make every engineer a programmer either, right? But you guys as leaders who actually understand the clinical use cases, right? If you can help engineers, either within your own organization or schools that are nearby, or even if you decide to partner with some other company, right? Understand what the need is that really matters, right? Because what happens is, I'll just bring up a story. Today, one of the most interesting ways that deep learning is being developed in healthcare is through challenges. So somebody would set up a challenge and say, I would like to, the most recent one was set up by Booz Allen Hamilton, Kaggle, and NIH. I want to early detect lung cancer. I think 10,000 people competed, right? And the results were phenomenal. We got great results, but what do you do with it now? Great, you have a way to early detect lung cancer. What are you going to do with it? How is it going to fit in the clinic? Whose life is it going to affect? We don't know that, right? So you guys, first of all, it would be amazing if you can get familiar with some of this technology, right? Which is not very difficult. There's a ton of articles on it. And then if you have the capability to partner with somebody, either within your institution, if you're in a sort of research institution, or if you're building a team, and that's NVIDIA where we come in. We provide sort of a platform, whether if you're building a team and you need education, we can actually provide something like that to you through our Deep Learning Institute. Or if you're trying to build a platform for yourself, we can actually supplement you also with this platform. We've not gone vertical before. The automotive industry is the first place we've gone vertical, where we've produced a whole platform end-to-end, hardware and software, to enable people to deploy self-driving. Healthcare is the next space we're doing that, and I'm always on the lookout. I mean, we partnered with MGH, as was mentioned earlier. I work with Mayo, in fact with OSU as well, at radiology department. But if somebody has an interest in developing this technology and platforms, I would love to partner with you and enable your team to do this.
Yeah, I think the key is developing multidisciplinary teams. It's really getting outside of our own specialties. This is part of what MD2K does by bringing together computer scientists, behavioral scientists, clinical and basic scientists, bioengineers, and so on and so forth. This is what I hear, a theme that I hear developing in industry. And quite frankly, if this really catches fire in industry will do this better than the NIH, because things will just move more quickly. But I think it's really creating those multidisciplinary teams and cutting across some of the barriers that have kept us apart in the past, because we don't understand each other and we don't necessarily speak the same language when we start out. But bringing those groups together can be incredibly powerful to this next generation of patient care.
Okay, so we have one more question, and then we're going to drink wine. And so okay. I know that people are getting thirsty sitting here. So.
Okay. Responsive to the last question that was asked, among other things I do, I'm a co-founder and chief medical officer of an artificial intelligence company. And to Abdul's point, you don't want to become programmers, but what you want to do is provide clinical perspective. I have clinical scientists, brilliant computer scientists, and what we as clinicians can do is provide the perspective of where these things need to go and how you apply them. And if you want to learn more about this stuff, there's a colleague that we all have, Jeremy Howard, who's developed training programs called in the fast AI space. And he trains the next generation of artificial intelligence people, and there's no reason why physicians can't be part of that. A lot of that's online.
Very good.
Okay, everybody, there's wine being passed around. Thank you for staying the whole time, your participation. We really value it. This is really the beginning. And take the surveys. It helps us get better each year.